Welcome to another episode of the Business Talk podcast. I'm Deepak, your host for today's conversation from India. We are delighted to welcome Dr. Laurel Austin, Associate Professor of Management Science at the Ivey Business School, Western University, is our distinguished guest for today's episode. Dr. Laurel is a behavioral and decision scientist whose work examines how individuals make choices under conditions of risk and uncertainty, with a particular focus on health and safety context. She is currently researching digital-first healthcare, including the use of digital triage tools and the rapid shift to virtual medical care during the COVID-19 pandemic, as well as social sciences and humanities research council funded work on how youth and young adults understand and decide about vaping, nicotine use, addiction, and cessation. Her prior research spans medical decision making, insurance choices, and behavior, electric worker safety decisions, computer supported group decision making, and abscol and risk taking. At Ivey Business School, Dr. Austin teaches decision making, organizational risk management, and building business resilience across SBA, MSc, MBA, and executive programs. Before joining Ivey, she served as an associate professor of strategic decision making and risk management at Copenhagen Business School in Denmark. She holds a PhD in management and decision sciences from Carnegie Mellon University and MSc in industrial and operational engineering from the University of Michigan. Today, Dr. Laurel Austin joins us to explore her groundbreaking research, risk uncertainty, and health decisions in the digital age, examining how behavioral and decision science illuminates the choices individuals make in healthcare, especially under crisis conditions such as COVID-19 pandemic. Let's not keep you waiting. Please join me in welcoming Dr. Laurel Austin to the podcast. Dr. Laurel, we are deeply appreciate your gracious presence and acceptance of our invitation. It's an honor and privilege to have you with us today.
Deepak, thank you. It's great to be here with you, and I really appreciate this opportunity to talk with you and to talk more broadly about health decisions in the digital age. So much is changing in this domain. There's so much being developed it's nice to have an opportunity to talk about that.
Thank you. Professor, during the COVID-19 pandemic, healthcare decisions shifted dramatically from planned, deliberative processes to urgent, high-stake choices, often made with incomplete information. How does your behavioral decision science framework help us understand people's decision-making processes when faced with immediate health threats and uncertainty in evolving medical guidance?
So that's a nice way to start this conversation, because we do have a framework that underlies a lot of our thinking in terms of research on how people make decisions and within behavioral decision sciences. And so what I want to talk about to give us a foundation for the rest of our conversation is dual process thinking. And this is an idea that really started with the seminal work of Amos Tversky and Daniel Kahneman and their work on how people make decisions. And their work was really motivated by sort of a reaction to the traditional economic perspective at the time on decision making, that we're very rational decision makers. We take in all the information and make rational decisions as we go. And Kahneman and Tversky started looking at how people actually do make decisions. And through their work, this idea of dual process thinking was developed. And so the idea is that we have two ways of thinking, and we can call it simply system one and system two. And system one thinking is very automated, unconscious. It's where we do our serial processing. We're able to take in information, hear things, see speech, read music, just take in visual information, process it in our brain really quickly, and make decisions and act. So a lot of our behaviors are the decisions that are going on are unconscious in our brain. So that's our system one thinking. System two thinking is that more analytical, deliberate, slow thinking that we do. So when we want to make a hard decision, if you want to build a bridge, for example, right, you want to think carefully about how are you doing this. And so you're going to block out distractions and really apply that slow, analytical, deliberative thinking. When we think about these two ways of thinking with respect to risk decisions, and any medical decision involves risk, of course. So there's the risk of am I sick, the condition that I might have. There's the risks associated with potential treatment or intervention. So any medical or health decision implicitly involves risk. When we think about dual process thinking, we often refer to it as two ways of thinking about risk or risk decision processes. So we think of risk as affect and risk as analysis. So the risk as affect is that system one thinking. Affect is that I see something, I hear something, I take in a situation, and I very quickly assess, is it good or bad? Do I like it or not? That's affect. And what we find is that often when people are thinking this way, in terms of assessing risk, what happens is our gut sort of tells us it's good or bad, I like this or that. And then our brain, our thinking, we sort of justify it, we rationalize it, thinking about the pros and cons that are consistent with what I've already decided I like to do. Risk as analysis is when we actually are using that more analytical decision making, taking into account the factors that matter, thinking about the pros and cons, and then deciding what should I do. And so what's interesting is how much our decisions often are guided, are driven by that gut level, affective, what do I want to do? What do I like? Automatic, then justify. We know emotions come into play. So think about the pandemic, and we didn't know much information. We really had to rely more on that sort of system one thinking. And I think that's where we got into trouble with sort of disinformation and people seeing things, hearing things that they sort of liked, or just latching onto things and then being willing to make not very good decisions, sort of driven largely by that system one affective decision making.
Professor, your research examines digital triage tools that emerged during the pandemic. From a decision-making perspective, how do these automated systems change the way a person's risk of a condition is assessed compared to a traditional in-person consultation with healthcare providers?
Yeah, thanks for asking. So I've been working with a group of about 6 other people the last several years looking at self-triage tools during the pandemic. And so we're still doing the analysis, and we're still working on that. Thinking about triage, so the first thing is, what is triage? Well, triage is assessing a person, assessing their risk, and then prioritizing them in the healthcare system. So do they need to go to an emergency department? Do they need to see a physician? Do they need to self-isolate during the pandemic? Can they go about their life and sort of watchful wait, just sort of see what happens and be cognizant and take things, change decisions as the situation changes. What we saw during the pandemic was this broad, vast experiment where many, maybe every country developed a digital triage tool that allowed people to self-triage, to go to the computer, type, answer some questions, and then get a response from the computer saying, you should go to the emergency room, or you should call your doctor, or go to this clinic that we've set up, or you should self-isolate, or, and giving you advice. And the systems varied. They varied in terms of what they asked, what they considered, what decisions they came up with, what they communicated. So they varied around the world. But at their core, they were all the same. They were trying to allow people to self-triage. Why these were something that countries turned to, and thinking of digital health decision aids in general, sort of the rationale. Why should we trust them? Why should we think they might help us make decisions better? In terms of, so this comes down to, or it goes back to automating expertise. There's a lot of research we've done that shows that experts in any field, not just medicine, but this research has been done in many fields, in banking, in medicine, in business, in investment decisions. Experts know the factors that matter in terms of predicting what's going to happen. And so if we think for medicine, what we're trying to do is assess your risk. And if the risk is above some level, we decide one thing. If it's below that level, we decide something else. And so there's all of this research showing that experts know the factors that matter. And if we take those factors that matter and build just a simple model, a simple predictive model, and predict what's going to happen. Or so predicting, for example, your risk of having COVID. What we find is that if we then give the experts and the automated system all of the same information, the automated systems do better at predicting than the same experts who told us what should go into the system, which is a little counterintuitive. But if you think about what we talked about a minute ago, system one and system two thinking, what happens to a physician, they're a human being, or to a nurse practitioner, to whoever it is you're going to, your advisor, they're a human being. They have that system one affective decision making going on. So they take in all of this information, but they can have those sort of automated affective, I think this is the right thing or the wrong thing to do, and be driven by that. We know that the human brain working memory can only take into account 3 to 7 chunks of information at a time. And after that, it's kind of overwhelmed. So there's a lot of noise in human decision processes. If you automate it with digital decision process, you take that all away. All the system does is consider what are the 8 factors you told me to consider, and then I'm going to predict something. And we find that systematically across all kinds of decisions, that does better. And so that's sort of the justification for why it makes sense to digitize to the extent that we can, because we know a lot about system things that matter. We're just trying to improve human decision making by automating. And so with all of those self-triage tools, that was sort of the premise behind that, right? And then there's other benefits we can talk about in terms of self-triage tools as well.
Professor, following on that, how might triage provided by a digital system change triage or care when compared to traditional in-person consultation with healthcare providers?
Yeah, so that and what you're asking really gets at, right? What are some of the pros and cons, the benefits, and maybe things to be concerned about with self-triage? Some of the benefits, the reasons we hope, the things we hope to get with self-triage, and especially during a time like a pandemic, or even now during high flu season, at least where I am in Ontario right now, it's high flu season and there's a lot of flu. So concerns are that healthcare systems get overwhelmed, and certainly during the pandemic and early in the pandemic, that was the concern that was driving this sort of move towards self-triage. We're concerned that the healthcare systems get overwhelmed and can't take it all in. We're concerned about potentially sick people going and sitting in a waiting room with potentially not sick people who are worried they're sick, but they're not. We're worried about spread to physicians, to the care providers, right? So digital triage offers the benefit of you can triage at home. You can triage in your car, on your phone with an app. So we take away sort of those interactions. So that's one thing. We maybe reduce spread. The digital tools offer the advantage that and during a pandemic, you talked earlier, Deepak, about uncertainty, right? And changing knowledge over time. As knowledge changes, as we learn more information, to change a digital tool just requires a programmer to go in and make the change that's appropriate. And then it happens everywhere for everyone. When we have human providers in every clinic, in every emergency department, in every tent that we set up, if we make a change to triage, we have to tell all of those human providers. And we have to hope that they understand it and that they remember to implement it and change the routine that they've been in. So it's much easier to make changes, especially in times of uncertainty and growing, changing information with those digital tools. Some of the concerns you asked about, well, how does it change triage? Some of the concerns people have, and it varies from person to person, the tools can't ask nuanced questions. Your provider can say, well, I don't understand what you're saying. Can you tell me more about that? And the digital tool right now can't do that. Maybe AI will change that. We're probably moving toward that. But what we had during the pandemic were very simple tools. So they couldn't do that kind of thing. They couldn't ask those sort of more nuanced questions. It couldn't actually see the person. Some people really like that face-to-face, one-on-one interaction. It can't do that. But these tools offer so much promise. It's just sort of overcoming some of the problems with the digital divide and and what we want to have, so how we feel about in-person consultations that maybe we're still working on.
Professor, when individuals use digital tools for health decisions, what role does trust play? Trust in the technology itself, trust in the data behind it, and trust in the healthcare institutions deploying it. And how did trust dynamics shift during the pandemic?
Yeah, so that's a really interesting question about trust, because trust is so important, right, in healthcare decisions. That's just critical. Um, so one thing that is true when we talk about digital tools, and especially tools you use yourself, because some digital health tools, of course, your provider is using, and some digital health tools you're using yourself, like these self-triage tools. Um, One thing we know from research has shown is that people tend to be less honest, or they're more willing to be dishonest when they're answering questions on a digital tool than when they're sitting face to face with another person. And so there is concern about that. And so we did interviews with, I think it was 20 people, residents in Ontario, just everyday people, and 14 medical providers during the pandemic. And one of the concerns with the digital self-triage tools was that, well, people decide what they want and they provide answers that get them what they want, right? And so that was one of the concerns the physicians had was, well, I can ask questions and sort of get around and get at that, where with the digital tool, there isn't anybody to do that. So there is that. There is potential that people are more willing to be a bit dishonest when they're answering tools with a digital system than when they are face to face with their provider. Another thing that came out after the pandemic, and this is unfortunate, and maybe I think the pandemic accelerated what was sort of going on already. But there's a study every year. It's called the Edelman Trust Barometer. In 2023, I was on a panel discussing the 2023 results. And so they're looking at trust in media and healthcare and in medical providers and so on every year. And one of the things they found in their 2023 report, or it was the 2024 report, reflecting on what they found in 2023, was that people's trust in the media and providers, the traditional media and providers, had fallen significantly since the pandemic. People put more trust in other people they knew, which of course they access via social media. And there were a lot of concerns, and so there was a real decrease in trust in medical providers, and turning to others you knew or social media and putting more trust in them. And that's probably not advantageous in terms of our healthcare system, right? We want people to trust the medical providers. So yeah, the role of trust in technology, some people don't trust it and don't want to use it. And so of course we have to have a system that allows for that, even as we move toward more digital health. But for sure, trust is important in healthcare decisions.
Professor, not all patients embrace digital first healthcare equally during the pandemic. What behavioral and psychological factors determine whether individuals feel more or less confident making health decisions through digital channels versus traditional means?
Oh, that's a good question. Certainly some people trust technology more than other people. For sure, in the interviews we did with people during the pandemic, maybe not surprisingly, older patients were often less trusting of technology. We know younger people are more trusting of technology generally, often prefer it to face-to-face communication. So age can be a factor. Technical sort of being just familiar, comfortable with technology, habit, right, and a sense of what care should be. We definitely heard from older people, well, they really need to be with their provider. They really want that human contact. They want to be able to sit and discuss with somebody. So really, I think those are probably the main factors, right, that we heard that were affecting whether someone was sort of open to digital healthcare, was their sort of view on how important it is to be with their provider and have that one-on-one conversation and contact, and then just familiarity, comfort with care. And then another thing, of course, is sort of access, right? Different people have different access to technology. So there is the digital divide. And even in Canada, where computers and smartphones are everywhere, we still have a definite digital divide. And that's going to be true to varying extents around the world. So that's a factor that would come into play.
Professor, cancer screening and other preventive digital tools require individuals to act on probabilistic risk information before symptoms appear. What should people consider in terms of uncertainty about true risk, false positives, and long-term outcomes when getting this kind of information?
Yeah, that's a really interesting area because we are all being offered so much more in terms of screening, which inherently involves digital technologies. In many places now you can go to a clinic or even maybe a shopping mall and ask for like a whole body MRI to look for potential problems, right, that I face. And so there's, I think, a lot of misunderstanding about preventive healthcare. And so it's something that digital tools are offering us more of, but we want to be careful that we're using them in the right way and that we understand them. Because when we do screening, mass screening, so take breast cancer screening, which is done around the world, typically advised at a certain age, maybe every couple of years. And so the idea is that we know that women at a certain age become at higher risk. It's still a low risk, but it's higher risk. And it's maybe high enough that we want to do preventive looking to see, screening to see, might there be a problem even though a person is asymptomatic, has no symptoms. The thing is that when we take a large group of people who don't have a condition, which most don't in our screening populations, then even though the technology doesn't offer us many false positives, they add up. So if you take it at the extreme, if you took a group of people where no one had the condition and the technology gave you 5% a false positive rate, well, every single one of those would be a false positive, right? Because if it was a group where nobody had the condition, by definition, any positive test result would be a false positive. And so what people don't realize is that when we do screening, we're screening in populations where the rate is still really low. And that means that if you get a positive result, the most likely thing is it's a false positive. And so with breast cancer screening, for example, if I remember the numbers right, a woman with symptoms, about 15% actually have breast cancer. In the screening population, it's only like 5 out of 1,000. And so if you work through the numbers and the technology and how accurate it is and the true positives and false positives, at the end of the day, if a woman who has a symptom gets a positive mammogram, for example, there's probably like an 80% chance she actually has breast cancer. So it's high, it's a high rate. For a woman who's in the screening population, the probability is more like 10 to 20%. It's actually very low. It might even be as low as 2%. It depends on a lot of things. So it's actually a low probability. So both people would want to look into that result and know more, but you certainly don't want both to jump to the conclusion that the test says they have cancer. But that's what people sort of understand, right? So I've done studies on this with people, and people say, well, it's the same test, it's the same result. It means the same thing to both women, but it doesn't. The statistics play out differently because the two started in very different places. One in a group where 15% chance of having breast cancer, one with a 5 in 1,000 chance of having breast cancer. So they're in very different places, but it feels the same. And so again, it goes to that system one thinking. It feels the same. I got the same result. And we don't intuitively do well with statistics. So when we talk about screening, we really want to be cognizant of the fact that if you have no symptoms, there isn't any other information suggesting something's wrong. And so just getting a test result saying there might be, you really want to take that with a grain of salt. And you really want to think, okay, maybe I want to look into this more. But the chances are I'm okay. And so when we're offering these screenings of the whole body. Everyone's body, lots of bodies have little imperfections that never do anything. And so there's risk, right? There's potential harm from treatment. So you don't want to overtreat. And that is the risk as we look at more and more screening of people who have no symptoms and helping them find problems that don't have symptoms. And then there's all kinds of ramifications, right? The more that money we pump into looking for potential problems and treating them, the less money we have to treat actual problems. And so those are important societal questions for how do we balance those things.
Professor, your research on youth mental models of vaping and nicotine use reveals how people construct understanding about health risks. How does these mental models, particularly around addiction and cessation, interact with the availability of digital health information and tools?
Yeah, so my research on vaping, youth and young adult vaping decisions is something I've also been doing for a few years, and it's very interesting. And as you asked, right now our focus is trying to understand youth and young adult mental models of vaping, addiction, and cessation, which is really complex. Addiction in itself is a really complex topic. We don't know a lot about how to help people cessate from vaping. Vaping is a complex topic because many health authorities around the world say, well, vaping is better than smoking. So if you're a smoker, it's a good idea to vape and reduce your harms. But we don't want young people to take it up. And unfortunately, it's being marketed to young people and they see it as fun. And they're hearing, well, it's not as bad as smoking. And I think what many of them are hearing is it's not bad, which isn't actually what experts believe. So we've been interviewing right now. We're in the process of, we just finished interviews with about 35 youth and young adults, so ages 16 to 21, talking to them to understand, as you asked about their mental models of vaping, cessation, addiction, how do they try to stop and so on. And then your question about, well, digital health and information and what role does that play in their mental models? And I think it's huge. Because there's lots of research showing that young people get their information from social media, and you might hear young people talk about doing medical research on TikTok. And as a researcher, I just say, oh my goodness, but this is where young people get information, right? And they see it as a medium to share information. And maybe it goes to that trust issue that you talked about before, that for whatever reason, people are trusting each other and sort of lived stories about my lived experience on TikTok more than experts, or being willing to talk to them. So I think their mental models are being informed a lot by what we're hearing about in our surveys are, TikTok, Reddit, Netflix, or YouTube rather. So these are the places that young people are getting information. They're getting information digitally through these mediums. It's unvetted information. We know there's concerns, of course, about influencers and are they sponsored or not, and who's sponsoring them, what motivates them to put information out there. But that's where people are getting. And then we also hear, it's interesting in talking to young people, that they'll talk some about going on the internet, other places to look for information, and some will even talk about looking at scientific reports. And then I don't know, since I don't see what they're looking at, are they actually looking at scientific reports, or are they looking at other things that are out there on the web that also might be subject to concerns about disinformation? And I have no idea. But certainly they think they're looking for scientific information. And so that's something I think to study further, is how do they do that and where are they looking?
Professor, after making health decisions through digital platforms, whether seeking virtual care or interpreting screening results, how do people experience decision satisfaction or regret? Does the mediated nature of digital decisions, affect how individuals process outcomes differently than in-person decisions?
Well, Deepak, I think you'd be a great researcher. That's a really good question. I think we don't know a whole lot about it, right? We do know that regret drives decision making. We know that uh, sometimes, so that often decisions are made. I don't want to regret the outcome, and that will drive people's decisions. They're thinking about what might happen. How will I feel about it? So all those emotions, right? Emotions are very important to us. So we know regret drives decisions. We know that people often regret decisions. Once you observe an outcome, then you might regret what you did. Uh, I don't know that we have information about how regret or potential for regret is impacted when we make decisions with digital tools. If there is research, I'm not aware of it. But it certainly would be an area we'd want to understand because, like I say, that affect emotions is so important to decision making, and there is a difference, of course, right? Working with my laptop as opposed to talking to my physician or talking to a psychologist or a counselor, an advisor. Um, there's a difference, and I don't think we, at least as far as I know, we don't have a good answer to your question. But I think it would be great for further study.
Professor, your work on computer-supported group decision making is relevant here. When families or couples make healthcare decisions with digital tools available, how does the dynamics differ from individual decision making? And what considerations emerge when multiple stakeholders are involved?
Okay, that's another great question, and probably one we need a lot more research on. And then it's interesting too because we have to take into account the different ways different cultures make decisions and think about health decisions. In some cultures, the family is expected to make a decision for a person about their health. And in other cultures, so for where I am, for example, in Canada, it's very much assumed that I make decisions for myself and I might seek the advice of my family or I might involve them in decision making, but that's my choice to do so. And so that's going to vary around the world, the way people approach this. Um, so, thinking about that and with digital tools, well, now, um, if I and my spouse, for example, were to go see my doctor, if I had an important decision and we went together to talk, my doctor would be observing how we interact, how we are talking to each other, who's doing the question answering, who seems to be understanding or not, and could for themselves as the provider decide where to direct their conversation, right, and their questions. And maybe they would do that differently depending on what culture. Canada's very multicultural. And maybe a doctor would approach it differently with people from different cultures knowing what their preferences are and their assumptions. Uh, but as you sort of are alluding to, when we're doing this digitally, there is no person there. There is no person observing what's going on with the person and their spouse or the person and their adult child or their parent or whatever. And so we take that away from the provider, that ability to see who's actually answering my questions, who's actually interpreting what I'm saying, what are the emotions on people's faces. We take that all away. And so I think, again, that's a really interesting question that you've asked, that I honestly haven't thought about before. But it's really important as we're thinking about using tools yourself. It's one thing if you're sitting with a provider and they're using the tool as you give them information. It's very different if you give a person an online tool and just trust who's giving the responses and so on. So again, I think we don't have good information about that, but I think that's important questions and something we're going to need to know more about going forward.
Professor, I'd like to conclude this episode with one last question. Drawing on your research across medical decisions, insurance choices, and safety decisions, what principles should designers of digital health tools follow to ensure technology addresses real needs in healthcare decision making and to ensure they are adopted by medical providers and patients? How can we help people make choices they feel confident about, even when imperfect information isn't available?
Okay, so I think we know some things. We don't know some things about the questions you've asked, so we're limited in what we know. Um, but I mentioned that we've been doing some research. We interviewed 14 providers and 20 people in Ontario about self-triage tools. And with the providers, our interest was, what do they know about these self-triage tools, and what do we learn from this experiment that took place during the pandemic? Because I think earlier I said it was a vast experiment across the world. Let's give people these self-triage tools so they can make decisions wherever they are, whenever they want to, so they aren't exposed to disease, so they aren't exposing others to disease, so we don't overwhelm the healthcare system. And so we said, well, this is an incredible experiment. What can we learn from this? What can we leverage for designing self-triage tools going forward? And in talking with the providers here in Ontario, and so context, it might vary depending on context and what tools were available and all kinds of things. But here in Ontario, what we found was first, that self-triage tool was very separated from the providers. It was available online for anyone to use, but your physician didn't know if you used it and they didn't get your results. And so it really removed the patient from their provider. And so what we found was that providers here might refer people to self-triage tools, but they typically referred them to ones they were familiar with, which maybe were developed by a local hospital or a local physician. And they would say, what was developed by this doctor, I know. And so that's really important. That was my sense, is it was really important to providers. They trust other providers. They know who they know are good providers. And maybe they weren't quite so sure about this tool by the government that's out there and doesn't interact with me. We found that right now, the providers we talk to seem to be more open to digital tools that help them do their triage, that get information before the visit and help them then in their consultation with the patient to make decisions. So they were more comfortable with that than they were with the idea of a self-triage tool that on itself sends you on to care, that tells you you should go see a dermatologist, or you should go to the emergency room, or you should do whatever the tool might be telling you. So they were more open to tools that help them do their triage, not so much to self-triage. And what the lessons we learned were that to make tools more acceptable, I guess would be the word, to providers, there should be certain design considerations, and that's what you were asking about. So one is, of course, they should be designed for conditions where a physical exam isn't necessary. And so that's maybe fairly intuitive, but still we use digital tools for lots of things. And so that was really important, right? That if the patient needs to see somebody in person, then of course you wouldn't want to bother digitizing that. Second, it should be easily integrated into their existing electronic medical record systems. And so that, again, varies around the world. And in Canada, we're still in the process where physicians are bringing those into their practices. But it was really important to them that they be able to get the result and integrate it into a person's records, right? And so with the system we had during the pandemic, that wasn't possible. Like I said, that was separate. So they didn't know their patient went to the tool. They didn't know what result they got. They didn't know what advice they were given or what they did. So that's really important. If we're going to build self-triage tools, then at least in Ontario, the physicians would like to know, well, what's going on with those? They'd like it to be integrated with them, not separate. Third design factor, it needs to be designed by physicians. Like I said, physicians trust other physicians, and they need to know that this tool was designed with the help of physicians, that there were physicians giving you advice on how to do it, that it wasn't someone trying to understand the health decisions and then designing the tool. And then finally, it needs to be able to be customized to fit local needs, right? And so again, during the pandemic, it mattered, depending on what resources were available, what a tool might tell you to do. Similarly, with a given physician, depending on their resources, do they have a room where they can see somebody who might be contagious or not? If they do, they can tell you to come in. If they don't have a room like that, they're going to tell you to go to an emergency room or to maybe another clinic. So the tools have to be able to be customized to fit the local context, including the local clinic context. And so our takeaway was, and it was we're basing this on interviews with 14 physicians or providers, some were nurse practitioners. So these are hypotheses we've come up with that maybe need further testing, but that's what we came up with would be 4 important considerations for designing self-triage tools that are going to be accepted by providers. Because if they're not accepted by providers, they're not going to have their patients use them. They're not going to promote them. And so that would be key.
Thank you, Professor Laurel Austin, for sharing your insights and experience with us today. Your work on risk, uncertainty, and health decisions in our increasingly digital world offers powerful guidance for both practitioners and policymakers and has given our listeners a lot of reflect on. It has been a pleasure having you on the Business Talk podcast, and we look forward to following your future research and contributions to this vital field. Thank you once again.
Thank you, Deepak, for having me. I've enjoyed our conversation, and it's an exciting area. So I hope your listeners find something that they can make use of through the podcast.
Thank you.